A very good morning, everyone. Today is 2nd November. Wish you a very happy Diwali to everyone. Today, we have a very important topic, very close to my heart. It talks about ENT problems, hearing loss, tinnitus, and vertigo. Uh, I think it's a problem in every household today. Most of the problems in this daily life today, a lot of old age people and in fact young age people are suffering. So it's a very, very important topic. And since it is a post-COVID, so we will talk about this. And to talk about this, we have our esteemed speaker, Professor Dr. J.M. Hans. He's a Padmashri Awardee. He has got a distinguished ENT surgeon and a senior director and HOD of ENT at Fortis Hospital, Vasant Kunj. He's renowned for pioneer cochlear implant surgeries in India with decades over experience. He has transformed countless lives with his expertise into hearing solutions. Honored with Padma Shri, he continued to lead enhancement at ENT. Today, he's talking about this topic. Sir, over to you.
Thank you, Saurabh. It's an honor to be talking here about a subject which is very, very close to my heart. I have been dealing with hearing loss, tinnitus, and vertigo for the last about 40 years now. When I was a professor at Ram Manohar Lohia Hospital, since then, I used to run a clinic on vertigo, tinnitus, and hearing loss every Tuesday. But those days, the kind of treatment we had for these things were very, very basic. As the time grew, these problems kept increasing, and our solutions also kept getting better. But it was post-COVID that I realized that if earlier I had about 10% of my patients suffering from these kind of symptoms in the total share of my ENT practice, rest being other conditions like allergies and cancers and other things. Post-COVID, I realized that almost 40% of my patients became patients with hearing loss, tinnitus, and vertigo. So I was getting very, uh, concerned about this. And when one day I read this article in the newspaper that 50% of COVID who were hospitalized, COVID patients who were hospitalized, are now ailing after 2 years. This was a Lancet thing, which I went into Lancet, then I read about it, and I realized that the prevalence of these clinical manifestation after long COVID had really, really risen. There were cardiovascular, neurological, all kind of things. But as far as ENT was concerned, dizziness had increased from 3% to 20%, and smell disorders, taste disorders, all these had also gone up. And I was concerned about dizziness, so I read about it in the literature and saw what was happening. And that's what I am going to tell you today about why post-COVID these problems increased. Now, as far as the prevalence is concerned, in adults, 1% of the patients, of these patients, were asymptomatic, 1% only. 99% were symptomatic. 81% had mild symptoms. 19% had very severe symptoms. On the contrary, children, 6% were asymptomatic and 94% were symptomatic. However, 99% were mild and only 1% children had severe symptoms. So that was the difference as far as the adults and the children were concerned. And they all used to come to us. And earlier it was difficult understanding why it is happening, but we used to treat them in the usual way. But when we understood, then we went into the depths of the problem and started treating the way, and the results were really, really very good. Now, we all know that these upper respiratory viruses, like the cytomegalovirus, the HIV virus, the rubella, mumps, rubella, varicella zoster, all these viruses, we know where exactly in the inner ear they affect. So I'll just give you an example of the mumps virus, that it affects the stria vascularis, it affects the organ of corti, and it also affects the neuronal system. So that means once you have mumps, the chances of recovery of hearing loss and vertigo are very, very late, and sometimes the hearing loss doesn't come back because it has destroyed completely the inner ear structures. Whereas the other things, other viruses, they affect maybe one thing or two things, and it is possible that we can reverse these conditions and treat them properly. But as far as COVID is concerned, as we didn't do any of these postmortems, we still don't know where exactly the lesion is and why some of them are improving so beautifully and the others are not. It still remains to be seen when we will do more postmortems in these patients and see where these problems are going. But in general, the most important structure which is getting affected is uh, uh, the endolymph, the inner ear, the endolymphatic system in the inner ear. So we have the cochlear part and the vestibular part. In the cochlea, we have the cochlear duct, and in the vestibule, we have the semicircular canals, the utricle, and the saccule, which get affected. And the fluid inside this, which is called the endolymph, gets affected. So now, before you understand how does this problem occur, you must understand also that how is this fluid forming and getting drained. The radial flow and the longitudinal flow of the endolymph. There are two ways by which these excretion of this fluid occurs, and the newer one is formed and the older one goes away. The radial flow means the dark cells in the vestibule and the stria in the cochlea are where this endolymph is formed, and it gets absorbed also in the same place. So it's a radial flow. So it is formed in the stria and goes back into the stria. Now, just imagine, just keep that in mind, that if there is anything problem in the stria, it may keep forming the endolymph, because that is an easier way, the formation. But the absorption is a very complicated way, like the glomeruli of the kidneys. If they may, the urine may come inside, but it is not filtered properly. And that's the reason why the problems of kidney failures occur. So the stria keeps forming the endolymph, but doesn't absorb it properly because of the problems which I'll tell you later. The second thing is the longitudinal flow. That means the endolymph is formed here, goes into the endolymphatic duct and into the endolymphatic sac. So problems of the endolymphatic duct, which I'll tell you shortly, are the ones which lead to the hydrops forming behind the endolymphatic system. So if there is a blockage here, the endolymph would keep increasing here and thus form hydrops. And that hydrops is the problem as far as these symptoms are concerned. So coming to the coronavirus, tinnitus, hearing loss, and vertigo, it has actually increased almost 25% in my OPD. And because I see most of these patients, my patients form really a big crunch of these problems. Now, what happened during COVID? There were two things: the virus per se and the associated stress. Now, please understand, the associated stress was equally important as the virus. Now, what did the stress do? I'll first take the stress into consideration. What did the stress do? The plasma levels of the stress-related hormones, such as the antidiuretics and the catecholamines, got elevated. So there was no diuresis, and the filtration in the stria vascularis did not occur, and there was a backlog of endolymph forming endolymphatic hydrops. These were the cause of alteration of the inner ear fluid dynamics, leading to the endolymphatic hydrops. The second was stress uses of the progesterone. Now, every person has progesterone and estrogen. Ladies have more estrogen, gents have more progesterone, but they have these ratio of progesterone and estrogen. Now, stress uses up the progesterone to manufacture the stress hormone called cortisol. And this leaves with a relative excess of estrogen. So it is this estrogen which causes the whole problem, as it does in contraceptive pills and pregnancies and etc. So stress also. So when the progesterone levels go down, there is a comparatively increase in estrogen levels, causing the whole thing. Stress also leads to vasoconstriction, and the vasoconstriction in the stria vascularis becomes a cause of this endolymphatic hydrops, leading to the problem and the symptoms. Disease may also worsen the emotional state. You get anxious, you get hyper, and which in turn may worsen the symptom perception. So when you have that problem that the dizziness may come, the tinnitus may bother you throughout the night, you get more apprehensive and that's how the symptoms get really, really bad. Now, just a word about the estrogen levels. Now, what does the high estrogen levels do? They lead to increase in blood viscosity. This may lead to sluggishness of the blood flow in the stria vascularis. I hope I told you what is stria vascularis. It is the blood circulation of the inner ear where the endolymphatis is formed and is absorbed. This causes a reduction in the fluid absorption in the stria vascularis, leading to endolymphatic hydrops, which happens in pregnancies, contraceptive pills, and stress. The low estrogen may lead to loosening of the otoconia, thus giving symptoms like BPPV. So menopause, when we have menopause and the lady comes to us with imbalance and a benign paroxysmal positional vertigo kind of a vertigo, we have to understand that it may be because of low estrogen in the body, and we have to do the assay, the progesterone estrogen assay, and see if the estrogen is less, we may have to replenish it. Whereas on the other side, we'll have to give the other hormone to balance the two hormones, and thus the side effect of estrogen may reduce. What does the virus do? Virus has three ways affects the inside of the cochlea. The direct damage, as I told you, it may affect directly the stria vascularis, the organ of corti, the neurons, etc. But it also induces an inflammatory virus response. So any virus would lead to inflammation of the intracochlear structures, leading to a debris, inflammatory debris which floats there. It goes and gets stuck into the endolymphatic duct, which is predisposed to these obstructions, and a backlog leading to an endolymphatic hydrops. Lastly, it causes immunosuppression. The virus causes immunosuppression, leading to increased susceptibility to bacterial infection. So if you don't treat it in time, the virus would lead to bacterial infection, and that is the ultimate. That will completely destroy the intracochlear structures and irreversible damage, and leading to hearing loss, tinnitus, and vertigo. Now, there are always predisposing factors. Why does one doesn't suffer and the other suffers? That is because this person probably was predisposed. Like if we have genetically predisposed to cancer, blood sugar, hypertension, then if the environment is such, stress environment or other environment, we will get these conditions of cancer and other things. So here also, genetic plays a big role. So if you are predisposed genetically to get these problems, you will get them immediately. Autoimmune, allergies, very, very important. Allergies cause an inflammatory response inside the cochlea, leading to these conditions. Ototoxic drugs. So if you're already on ototoxic drug and there is lesion inside the cochlea, like aspirin, catecholamines, etc., there is a problem that the virus will go and get stuck there and lead to further damage. Anatomical variations of the mastoid, and I'm talking about the Trotman's triangle. This Trotman's triangle area harbors the endolymphatic duct. So if it is narrow, the endolymphatic duct would be narrow, it will kink, and leading to problems of endolymphatic hydrops. And last but not the least, the hormonal variations, which I've already talked about. Very important. You have to keep that in mind. And if the patient is not getting better, get these hormonal assays done and treat them properly. Now, what were the most common conditions seen? The most common conditions seen were the endolymphatic hydrops, which I today don't say Meniere's is an idiopathic disorder. There was always some endolymphatic hydrops. And if stress is what the Meniere's is causing, it doesn't mean that it is idiopathic. Then we have BPPV, vestibular migraine, we have labyrinthitis, we have vestibulopathy. So these were the 5 major conditions, but all of these have to be diagnosed precisely to be treating them properly, because all these conditions have a similar symptomatology, but the treatment is totally different. One drug may not be benefited in one condition, but it will be like a very good drug for the other condition. So we have to what happens till today was that if you don't do these investigations, don't diagnose this thing properly, then what happens? People just keep giving Vertin, Stugeron, Stemetil, Finargan. They are all vestibulosedative drugs. It further sedates the vestibule and leading to what is called a vestibulopathy. So I give an example always that if a friend of yours is depressed and in the evening you give him alcohol, he may tide over that evening, but later next morning he'll be further depressed. So don't don't give vestibular suppressant drugs for very, very long time. Diagnose the condition and then treat it properly. So earlier, 20 years back, we only had history and maybe the audiometry to tell us what this problem probably is. But today we have CC, we have ECOG, electrocochleography, VAMP, vestibular evoked muscle potentials, impedance, very important. You may say, why? Because this is primarily sensory neural loss. No, if there is a mixed loss and the impedance is normal, the chances are that probably this is inner ear conductive loss. That means the time taken for the sound wave to travel from the stapes to the organ of Corti increases because of endolymphatic hydrops, leading to what we call inner ear conductive loss and thus a mixed loss. Lastly, we also have to do a complete vestibular assessment. We have to do these other tests to find out if it is only one condition or there are multiple conditions existing. So if we keep treating one condition and don't treat the adjoining conditions, the associated conditions, then we will not be able to treat the patient properly. And that's the reason. It is because of these tests that we are able to stage our problem, like the prodromic stage, the fluctuating stage, the disabling stage, the stabilized stage, and the contralateral ear stage. Now, why this staging is important is because we can treat and we can give prognosis to the patient properly. If somebody has come at a disabling stage, these three conditions are reversible. You may be able to treat and reverse the situation. The hearing loss may improve, the tinnitus may go down, and the vertigo may get better. But once you get into the stabilized stage and the contralateral ear stage, you can only lower the problems, but you can't completely treat it forever. So that's the thing. And the different permutation combinations can actually, the audiogram, CC, and the ECOG can give us what stage the disease is, what scenario the stage is, and if we have a stage in front of us, we can tell the patients, no, you have come late. Only these things would get better. Your vertigo may get better. Your hearing loss may improve by only 10 to 20%, and your tinnitus may reduce, but it will not go completely. But in the first 2-3 stages, you can tell the patient, you can be sure that it will go back and become absolutely normal. So that's the importance of these clinical staging. And it is very important that we do all these tests to know what stage the disease is. And in the different types of tests done for complete vestibular assessment, we have the VNG, we have the caloric test, we have the SVV, SVH, VAMP, Dix-Hallpike, and the rotary chair test. We in our clinic have all these latest tests to diagnose, to rule out conditions like vestibular migraine, BPPV, etc., along with endolymphatic hydrops. So even BPPV, as I'll tell you later, are about 15 different types. Earlier, we used to know there is only one type, and we would do applies and try to treat the patient, but the patient would not get better. Today, with these instruments, we can actually find out which type of BPPV out of the 15 you have is this, and we can treat them properly. Yes, other tests are also required. These are the thyroid function tests, the vitamin B12, D3 levels, P-ANCA and C-ANCA to exclude autoimmune disorder, the allergy tests to find out what allergies these patients are suffering from so that we can correct them and do that. Hormonal assays, as I told you, progesterone, estrogen, HRCT, and MRI. HRCT will tell us whether it is a sclerotic mastoid or there is an endolymphatic hydrops. MRI will tell us whether there is intracanalicular schwannoma, which is pressing onto the drainage of the inner ear, leading to a backlog, leading to what we call as secondary endolymphatic hydrops. So these things are important, and to know the diagnosis and give the prognosis, all these conditions are very, very important. Just a word about what these three conditions are, which are the most common one, the endolymphatic hydrops and the Meniere's. Now, once you have episodic vertigo, you have fluctuating hearing loss, you have roaring tinnitus, we will call it Meniere's. But we have to diagnose this condition much earlier. And blocked ear and vague symptoms, which I'll tell you, are what endolymphatic hydrops is all about. And as I told you, that we will be able to diagnose the condition in the first three stages, so that we can reverse the condition. We can treat and reverse the situation rather than diagnose when it is Meniere's disease and it is too late. Now, causes of secondary endolymphatic hydrops are surgeries on the ear, viral or vascular trauma, toxic labyrinthitis, ototoxic drugs, and acoustic nerve tumors. So these conditions also have to be diagnosed, whereas these can cause endolymphatic hydrops secondary. Now, the most important part is that most damaging, this condition is most damaging in the first year. So, if you have overlooked the symptoms and not treated the patient in the early stages, when there is oral blockage of the ear, deep seated ear pain, burning sensation in the ear, and feeling of fluid in the ear, if you don't diagnose them when the patient comes to you with this and say, no, no, there is nothing wrong, the audiogram is normal, the CC is normal, you may miss. So ECOG is very important. And at this stage, the ECOG may be positive or borderline, and you have it in mind that there is a problem which is there and you have to treat that. Other conditions are Tullio phenomenon and hyperacusis. Hyperacusis is a very, very thing. The patient will tell us that I get disturbed with sound and noise, and I can't bear it. I have to go and sit in a quiet condition. And every time you will think probably it is only vestibular migraine. No, it could be early stages of endolymphatic hydrops, and this has to be treated in time. Tinnitus, hearing loss, vertigo, by the time it is late, and the chances are that you will not be able to completely reverse the situation as you do in the early stages. So diagnosing in the early stage is very, very important. And as I say, mostly affects the pars inferior. That means the cochlear nerve. Gravitationally in the body, this is the lower part, and that's why it is called the pars inferior. So the first most important symptom is the tinnitus. Don't overlook tinnitus. What we used to say earlier, that tinnitus is an idiopathic condition. No, nothing in nature is idiopathic. There is always something. Nature is trying to tell you, like the tsunamis, like the the rains which are coming and the floodings which is happening. This is all telling us that global warming is occurring, and if we don't take this seriously, one day it will be a disaster. Similarly, tinnitus is a precursor. It is just telling us that there is a problem. Please look into it. Don't say, no, you'll have to live with this. Don't say that there is no problem. Please try to find out, because this is nature's way of telling you there is a problem occurring, and don't say it is idiopathic and you can't treat it. So it is the endolymphatic valve or the bast valve which doesn't let the endolymph hydrops go into the vestibular part in the initial stages, and you may not have vertigo. You may have only tinnitus till it bursts, the valve bursts, and it goes into the vestibular system also, and you have vertigo. So variance, please understand the variance of endolymphatic hydrops, which is vague symptoms, cochlear or vestibular hydrops, endolymphatic hydrops, and lastly, but not the least, the Meniere's disease. But you should also look about drop attacks. Suddenly the endolymph increases, it bursts into the perilymph, and you have to mark in otolithic crisis or rupture of the membrane, leading to sudden mixing of the endolymph and perilymph. So it is drop attacks, very, very important. Some patients will just come with drop attacks. They are sitting and suddenly they fall and they get a severe vertigo. And after 2-3 hours, once the endolymph drains back and the whole system comes back to normal, they may improve. But every attack would keep reducing their problem, increasing their problem, and the hearing loss and tinnitus may keep increasing. Now, coming to another condition called the paroxysmal positional vertigo, the BPPV. Please understand, it can be in the canal. These are the canals, the canal lithiasis. The otoliths can be in the canal. The otoliths can be in the cupula. Now, these are the cupulas. The three are the cupulas, the opening, the ampullary system. So, the otoliths can be here. So, when you combine these two conditions, the right, left, the anterior, lateral, and the posterior canal, the cupula and the canal, there could be 15 types of BPPV and the multi-canal types also. And there is a different repositioning maneuver to to remove these otoliths and put it in the utricle, which is called the dustbin of the ear. There are different repositioning maneuvers, and you should know exactly what type of BPPV this is. Otherwise, what people do is keep doing the applies and leading it to a multi-canal BPPV, which becomes a very, very difficult situation then to treat. Lastly, I'm talking about vestibular migraine, the headache associated with dizziness, ear pain, and tinnitus. There is an abnormal electrical signal in the brain leading to hypersensitivity to stimulus. So it may mimic as a hyperacusis as seen in endolymphatic hydrops, but it is only hypersensitivity. There is no hyperacusis. The predisposing conditions are less sleep, too much TV, computer, phone, etc., foods like MSG, chocolates, aerated drinks, and alcohol. So again, you have to diagnose this condition by excluding the other conditions and treat it properly, and also tell the precautions, which are very, very important. Now, the management. The most important is management, and only drugs cannot treat these conditions. Only drugs cannot. Psychotherapy is very, very important. You will have to tell the patients, yes, we have diagnosed it properly, and now you will be better. It depends upon what stage you are, and that's how time will take. Medical management and surgical management. Earlier, we used to do sac decompression surgeries, vestibular neuronectomies. Today, with modern medicine and intratympanic installations of steroids and gentamicin, we can treat it without doing those destructive conditions. Now, the drugs are beta histine, piracetam, diuretics, and steroids. I will talk first about beta histine and piracetam. They both are vasodilators. This hinders vasospasm, improves microcirculation of the intracochlear structures, and similarly, beta histine also does that. So, as I told you earlier, the most important thing in stress, and these are all psychosomatic disorders, stress-induced disorder, the most important thing is stress leading to vasoconstriction. And that's the reason why the other drugs, what we give, the steroids, what we give, don't even reach this area. So first and foremost is to give these two drugs, so there is vasodilation. The drugs can reach that area properly and treat the. So vasodilators like beta histine and piracetam are very, very important. The diuretics are very important because if there is endolymphatic hydrops and we don't let the endolymph drain out, we will not be able to treat this condition. Steroids are anti-inflammatory. They remove the obstruction in the endolymphatic duct. They increase the stria vascularis circulation. And as I told you, if you give them orally, there are side effects of increased diabetes, increased body weight, acidity, etc., etc. So intratympanic is the best way to do it. And today we are treating almost 80% of patients in the early stages completely. They become normal because it reduces the inflammatory process in the labyrinth. It restores the normal functioning of the stria. It regulates the inner ear de novo protein synthesis. It improves excretion via the longitudinal flow, and it improves intracochlear vascularity. Now, all these conditions try to revert back the condition of the endolymph to a normal situation, which the high estrogen level, the vasoconstriction in the endolymphatic duct system and the debris there, it treats on a whole this system. But as I tell you, both the things are important. The drugs are important, the psychotherapy is important, and the intra-tympanic steroids are also important. And this is how we give it. You give it under the microscope or endoscopically also given. Can you see here the fluid is put inside and the patient's head is tilted to the same side, so that otherwise it will go out of the station tube. And you ask the patient not to swallow and not to talk, because that would increase the excretion for the station tube. Just ask them, the patient, to lie down there for 25 minutes, sorry, so that it goes into the endolymph, where into the inner ear through the round window, so that it gets absorbed from there. Yes, intratympanic decadron is very important in acute tinnitus, sudden sensorineural hearing loss, endolymphatic hydrops, and Meniere's disease. For chronic tinnitus, sometimes these things don't work, and we have to match that tinnitus and give a masking app. Very good thing. We give a masking app and we give it in the phone of the patient, this app, and he can just put it in the 1 hour in the morning and 1 hour in the evening, and the tinnitus goes away. Because most of the time we know that tinnitus now becomes a phantom noise. There was a disease and now the brain is not forgetting it. So we try to uh, mask that brain and treat chronic tinnitus this way. The vestibular lab, we have a uh, very superior lab in our OPD where we can diagnose this condition very properly. We have a vestibular habilitation lab where conditions like vestibulopathy is treated by giving them exercise, which is electronically maintained. These are very, very important things. And we have this clinic where all these conditions are done. We have a CBCT head, we can do an HRCT temporal bone immediately. We have all these BERAs and skin prick allergic tests. We have a very good audiometry room where we can diagnose these conditions. And these are important if you think that uh, you have to diagnose and treat these conditions properly. Thank you very much.
Hello.
Yeah, Saurabh.
So thank you so much. We can close the screen now.
Yeah, okay.
So wonderful audience, sir. I think a very important topic, as I was sure about it. So we have Dr. Chong here and we have Dr. Maria. Dr. Chong is the chairman for CMAAO and Dr. Maria is a president. So before we can move forward, I would like to invite Dr. Chong for comments. Dr. Chong, please, your comments.
Thank you, Professor Hans, for your wonderful talk on the vestibular system.
Thank you.
We
Thank
see
you, Dr.
actually, yes, thank you. By the way, happy Diwali.
Happy Diwali to you too. Thank you very much.
And yeah, I see quite a lot of vestibular neuronitis in a week. For example, I can see a few patients, so I understand the difficulties in trying to figure out whether is it BPPV or is a vestibular neuronitis or something else, which then we have to get our ENT colleagues to address.
No, and Dr. Chong, you would be surprised that sometimes 2 to 3 conditions are associated simultaneously. You can have endoliphatic hydrops, which is leading to BPPV and leading to vestibular migraine. I give an example that there is an aeroplane with a malfunctioning engine, and the pilot is able to fly that thing, but suddenly there is a storm which comes, and he is able to tide over the aeroplane through that also. But after he comes out of the storm, he has a very bad headache. And I give the example of this being as vestibular migraine, which was primarily because of the endolymphatic hydrops and the BPPV for so many months and weeks. And you have to diagnose that all these 3 conditions simultaneously, you'll have to treat them. Otherwise, the patient will keep getting the episodes again and again.
Yeah, I myself have on occasion done the Apne's maneuver for my patient, which was quite a useful thing. Even I've done that. So yeah, I appreciate what you've just summarized for us today. It's actually sometimes we feel very helpless about this vertigo condition. We feel very helpless, but you can see that it's very debilitating for the patients. And even I have this gentleman who is still suffering the after effects now 3-4 years later. He's still not completely with it, but much better, almost 99%, but still not.
BPPV, I'll tell you, BPPV is like that, have you seen that toy in which you shake it and the particles go in the fluid there? Exactly like that. So what happens is these patients don't shake their head so vigorously. They start living like that. and the otoliths are lying in one corner, and the moment they have a head shake, the BPPV comes back again. So they have to be put back into the utricle, diagnose and do a proper maneuvering and put it back into the utricle, so where they need to be.
Thank you, Professor Hans. And I'd like to get Dr. Kalima, who is our president of CMAAO, to say a few words. Dr. Kalima?
Hello. Hello, everyone.
Hello, ma'am.
Sir, Hans, for that very enlightening lecture. Indeed, we have to focus on this side effects of COVID, because it's here to stay with us.
Yes,
Even
it is.
pandemic. And I note that you've been tracking at least an increase of this side effects, Professor.
Yeah, too many of them. You know, as an ENT guy, we have this loss of smell, loss of taste, but not because I am particularly dealing in the inner ear for the last 25 years. I was the first one who started the cochlear implants in India. So inner ear is very, very close to my heart. And because the stapes is also part of the inner ear because of embryology, I do the stapedectomy also and the cochlear implants. And I also am very particular about treating vertigo, which can occur after cochlear implant or can occur, the Meniere's would lead to total deafness and we have to do a cochlear implant. So the inner ear is so close to my heart that I deal in all these three things. And post-COVID, I'm seeing that it has increased by 25, at least by 25%.
So perhaps we can see a trend all over the different NMAs. Yeah, so we can track this down also and perhaps report on it, right?
Yes.
Thank you, Professor. Thank you for that.
You.
Thank you, Dr. Chong.
Thank you.
Thank you, President. Thank you, President.
Thank you. Thank you very much.
Do we have any questions from the floor?
We have a question online on Facebook which says that, is it safe to carry the medicines for vertigo, which is probably Vertin or Strujon, for a lifetime? Is it safe to carry that medicine?
Never. The vestibular sedatives like the cinerazine should never be given. Stemetil, cinerazine, Finargan. These are all vestibular sedatives. Should not be given for more than 1 week. The vestibular stimulants like the beta histine can be given for a longer period, because in longer period they have an effect of vasodilation also. So they are vestibular stimulants. The cinerazine, like Stugeron, etc., are vestibular sedatives. We should not be given for more than a week at all.
That's safe for those who are driving or doing other.
Absolutely.
So even Vertin?
So Dr. Hans, the treatment differs in case it is non-COVID or COVID.
No. Same.
So we need not concentrate on that part.
No. It is just that I realized in my clinical practice that probably these are the conditions, and coronavirus was no different than the other viruses which we had, which had a predilection to the inner ear, leading to all these conditions. See, when we call off labyrinthitis, viral labyrinthitis, it can happen with mumps, it can happen with measles, and it can happen also with corona. So corona, we have now to keep it in mind that this virus also, COVID virus, is also a cause, and we have to keep that in mind now. That's all. Otherwise, no difference in treatment.
Professor, I would like to recognize Dr. Norby Martinez in the audience. He's a prominent ENT specialist in the Philippines. Perhaps, Martinez, you'd like to ask a question?
First of all, I would like to congratulate Professor Hans for a very extensive lecture on this topic, hearing loss, tinnitus and vertigo. Just like Dr. Hans, the inner ear is close to my heart. I've been in practice in this field for almost 33 years now.
Oh, nice meeting you.
Yeah, so congratulations.
Thank you very much.
We have encountered this type of patients as well, especially in the outpatient section. and more so in the emergency room, patients suffering from acute vertigo. Unfortunately, a lot of these patients are misdiagnosed as stroke. So these patients will come in and will have a CT scan or an MRI, and BPPV patients undergoing a CT scan, even patients with vestibular neuritis under CT scan, even MRI, they are underdiagnosed or overdiagnosed. So that's a problem, no? So it's very important for our emergency room physicians to have a clear understanding regarding the HINTS test and the maneuvers, the big sulfite maneuver, as well as the treatment FD maneuver. So thank you, and I'm glad that you touched on this topic. Thank you so much.
No, and sir, I would like to tell you that unfortunately for the ENT, 85% of vertigo is because of the labyrinth. But we are the last ones and the most delayed ones to get these patients. By the time the patient has developed multiple conditions, as I told you, he had endolymphatic hydrops and now they also have vestibular migraine. So they are in a miserable situation. They have gone through the cardiologist, the neurologist, the psychiatrist also. Can you believe there are many patients I've got who had psychiatric problem labeled as psychiatric conditions for very, very long, and they got treated, and they had only a multi-canal BPPV, and they got treated and they became better. By the time 8 months, 9 months, the husbands were fed up of their wives. If they were wives, nobody did the estrogen levels in post-menopausal conditions. Nobody even diagnosed that, and they were labeled as psychosomatic.
Professor Hans, you'll be happy to know that I do a Dix-Hallpike test for all my patients with dizziness.
That's very important, sir. That's very, very important. That's very, very important.
Yeah. So
if you have the Frenzel's glasses also, that will be a beautiful thing.
I don't have those, but I just do the Dix-Hallpike test. It's quite simple to do. I mean,
no, that's
it's
very
a very
good.
simple thing. The
Frenzel's glasses can actually stop the visual fixation and reduce the nystagmus. So if you have Frenzel glasses, your diagnosis would even be better.
I'll look into acquiring a pair of those.
Yes, sir.
Anything else from the floor, Dr. Kalima?
Just like to acknowledge Dr. Hector Santos, President of the Philippine Medical Association, the audience.
Dr. Hector Santos, welcome.
Thank you.
Good morning.
You saw each other in Helsinki.
So, Dr. Hector, you have any comments?
Yeah, I'm yet to see any real success with but I've been working through my contacts.
Okay, Dr. Hans, I think a repeat question from that person. This person is on Vertin for last 4 years now.
No, we have to diagnose it. We have to diagnose the condition. Vertin is like giving paracetamol in fever. Please understand. We have to diagnose whether it is malaria, typhoid, what fever is this? Giving Vertin is like giving paracetamol for long. We don't know what kind of fever is that. So that fever is to be diagnosed, that condition is to be diagnosed and then treated properly. 4 years is a big time for having not diagnosed the thing properly.
Yeah.
Okay. Dr. Akhtar Hussain, you are here. You want to make any comments? Dr. Mukti, you're here. You want to make any comments? And anyone else on the floor want to make any comments?
I have a question.
Sure.
Yes.
No, thank you. No, any question.
Yeah, I am an oncologist and I have come across 2 patients. One was like 45 and another is 38 years old and diagnosed with, tinnitus and severe, there was a sensory neural loss. And this patient underwent, educated patient. So they underwent investigations very fast and they were diagnosed as vestibular schwannoma. 2 patients consecutively post-COVID. Yeah. And now they have, one patient went for, is just not ready to take treatment. The second patient has taken steroid injections in the ear and then he was given radiotherapy. He was given static radiotherapy, this gamma knife. Now, after that, the problem is that 6 months he was fine, but now the symptoms are recurring. And he says that vertigo is again there and heaviness is there in the ear. and his shoulder on the say ipsilateral, the side of the lesion, his shoulder is having reddish lesions, over the deltoid. So I don't know if, I mean, with the vestibular schwannoma, do you have any kind of these kind of picture? Have you seen anything like this?
Yeah, see, as I told you in my lecture, that vestibular schwannoma can lead to the obstruction of the venous drainage of the inner ear, leading to what is called a secondary hydrops. So very rightly, it has to be treated not only by the gamma knife, intratympanic decadron to increase the outflow of endolymph also, and the treatment in the form. Secondary hydrops will be treated as secondary hydrops, and the schwannoma would be treated. Now, unfortunately, after a gamma knife, there is a fibrosis in that area in the sheath, further leading to blockage of the venous drainage of the inner ear, and the vertigo and the hearing loss may persist. So you have to keep treating these patients with long-term Diamox and intratympanic decadron SOS. So whenever they have a problem, give them intratympanic decadron, give them Diamox, reduce the salt intake, the stress intake. So all these conditions, though it is a secondary hydrops, because of the schwannoma has to be treated, but also the secondary hydrops has to be treated simultaneously. Now, as far as the thing on the shoulder is concerned, I think the whole body needs to be seen. Maybe he has some allergies, and those allergies have to be treated by first diagnosis by a skin prick allergy test or a CRD blood allergy test, and immunotherapy. We give vaccines for these allergies. That also need to be seen and treated properly. So, maybe you have only seen it in the shoulder and there at the back and other places also. So we have to see whether the patient is suffering from any allergies, and that also needs to be treated.
Okay. Okay. Thank you, sir.
Dr. Mufti, quick comments, please. You were saying something? Dr. Hussain?
No comments. Thank you.
Okay. So I think we just have one comments in the chat box, which says, very interesting topic, Dr. Hans. Thank you. I've been treating many cases post-COVID, POTS, for long COVID. All parts are coming together. Dizziness from POTS also can mimic BPPV, common with many generic conditions. This is Dr. Anjali Agarwal.
So, I think you should put this on the YouTube. This should be very, very important for those who could not attend.
Absolutely, sir. It is on YouTube and it is on almost like 6 platforms right now. As we talk, we are on LinkedIn, we are on Facebook, we are on YouTube, and I will share all the links. People who want these links will come on the email also. I will send you the link, sir.
Thank you. Thank you very much.
So if you don't have any comments, any forward, I think Dr. Hans has to rush to the hospital. He had an appointment at 9, I think.
So thank you, Dr. Chong. Thank you very much for being there. Thank you, Saurabh. Thank you, madam. It was nice to have you all. Thank you very much.
Thank you, Dr. Hans. Much
you.
Appreciated your lecture. Thank you.
Thank you very much, sir. Thank you very much. Thank you.
Thank you, Dr. Hans. We'll see you again. You've been very helpful for us. Thank you so much.
Thank you.
Thank you
very much.
Thank you again.